Good afternoon and welcome to all of you who have joined us today. My name is Shirley-Ann James and I'm the editor of the Daily Dispatch newspaper. Next Tuesday on December 1, the world will observe World AIDS Day. The HIV epidemic remains a major health crisis not only in South Africa, but in the world. However, we are currently faced with the COVID-19 pandemic, which has already claimed more than 1.3 million lives globally. At the World AIDS Conference this year, UNAIDS announced that the world could lose 10 years of gains made in the HIV response. Today, we have partnered with the Eastern Cape AIDS Council to explore how to regain the lost ground on HIV due to COVID-19. Introducing our distinguished panel of speakers for this afternoon session is Vuyisa Dayile, the head of the Eastern Cape AIDS Council.
Okay, thank you, Shirley-Ann. Good evening, colleagues. Good evening, everyone. First of all, I just wanted to apologize on behalf of the MEC for Health in the Eastern Cape province, who's also the chairperson of the Eastern Cape AIDS Council. Colleagues, I just wanted to introduce our very beautiful panelists here today. We've got a number of them here seated with us. Others are joining us virtually. We've got Dr. Mbulawo Mugabe from UNAIDS. He is the country director for UNAIDS in South Africa. We've got Ms. Coceka Nokoduka. She is working for Senec as the executive director for the National Strategic Plan. We've got Dr. Bulumko Fuchane. He is the program director for the Global Fund in Beyond Zero. And we also have Ms. Miya Nokwe. She is the chief director of the Department of Health in the Eastern Cape province. We also have Comrade Anele Yawa. He is the secretary general of the Treatment Action Campaign. And we have Ms. Steve Lesike. She is the chairperson of civil society at Senec. She is also the deputy chairperson of Senec. Thank you very much, Chair. And colleagues, may you please enjoy yourselves. Thank you.
Thank you so much, Vuyisa. Okay, we will now head over to our speakers. And our first speaker this afternoon will be Anele Yaya, who is with the Treatment Action Campaign. Apologies. Anele, would you like to take us through some of your thoughts on the topic this afternoon?
Thank you. Greetings to everybody. Just a point of correction. My name is Anele Yawa, not Yaya. Yawa.
Apologies for that.
Thank you. This is a good topic for us as the people of South Africa, more especially those of Eastern Cape, to talk about regaining the lost ground on HIV due to COVID-19. I'm not going to dwell much about the problems that the whole world knows about the state of our HIV and TB response as the country, as well as about the state of healthcare systems in the country. But I think what needs to be done to regain the lost ground, firstly, it is around the human resource for health. It's a pity that the MEC is decided not to join this session, but within Eastern Cape, we've got many frozen posts with regards to human resources. And we think that the MEC and her team must unfreeze all the frozen posts. COVID-19 came with disruptions, and many healthcare workers have succumbed to COVID-19. That created a lot of vacancies in our healthcare facilities, and those vacancies are not filled until now. They need to be filled as a matter of urgency. The second issue is around infrastructure. We think that our government needs to prioritize the issue of refurbishment of the existing healthcare facilities, to building of new healthcare facilities, for the destitute communities. And the other issue is around the availability of medicine. We know that on many occasions, people living with HIV, TB, and other chronic illnesses are often turned away in clinics because of the shortage of medicines and medicine stock out. And in some instances, people are given wrong medication because in some facilities, healthcare workers, they just want to get rid of these people and make them go away, and they will just give them any medicine. The other issue is around the emergency medical services. So Eastern Cape has a problem with regard to the shortage of ambulances. And we think that the Eastern Cape government must prioritize the purchase of ambulances for each and every community, each and every facility. But also in Eastern Cape, we've got a lot of ambulances that are parked outside the buildings of the DOH. They are broken. And we believe that if the NEC can take the money that she spent to buy the scooter bikes, return those scooter bikes, take that money and fix those ambulances that are parked outside the Department of Health, the people of Eastern Cape will see a change. And also, we have seen during lockdown level 5 to level 1, many clinics gates are closed because healthcare practitioners are fearing to contract COVID-19 because they have inadequate PPE. But that is exposing patients, people living with HIV, TB, and other chronic illnesses to all kinds of weather. People are locked outside the gate and they are taken in certain numbers. And as a result of that, other people, they get tired of waiting outside and they end up going home barehanded without getting the medicines that they are looking for. The other issue, it is around the staff attitude. Many people living with HIV and TB are defaulting on their treatment or are changing clinics because one or another reason that is caused by healthcare practitioners who've got a negative attitude to patients, who are disclosing the status of people without the consent of the people, which we view it as a contributing factor to the number of people who are lost on follow-up. Also, we have seen during the lockdown 5 to 1, where the COVID-19 response as the country was not integrated to HIV and TB response. We strongly believe that if our response as the country to COVID-19 can be integrated to HIV and TB services, more services can improve in terms of people accessing them. But also, we all know that according to the World Health Organization report of 2019, it shows that in South Africa, about 301,000 people contracted tuberculosis. Between 60 to 63,000 people in South Africa died of tuberculosis. And 40,000 of those people who died of tuberculosis are people living with HIV. It is against that reason, as the sector of people living with HIV, we are calling upon our government to declare tuberculosis as a public health emergency. We are demanding that the president of the country and all those who are holding positions of power, civil society, UNAIDS, PEPFAR, and everybody, we are calling them to join our struggle where we are demanding that TB must be declared as the public health emergency and make sure that all the efforts that we see from our government, starting from injection of resources to COVID-19, we want to see the same thing happening on TB, where the minister on daily basis is giving the people of South Africa statistics about the number of people who have contracted COVID, about the number of people who have recovered on COVID, and the number of people who have died of COVID. We will be glad if we can see the same happening with regards to our response to tuberculosis. And we don't see the fact that tuberculosis in South Africa is the #1 killer disease. If you can compare the number of people who died of tuberculosis as compared to those who died of COVID-19, you will realize that COVID-19 is not a threat more than tuberculosis, but many of us who don't see that. Lastly, we are calling upon the political leaders, we are calling them to commit themselves. It can't be true that we will have the Eastern Cape AIDS Council that is led by the MEC, yet we know that the Eastern Cape AIDS Council is supposed to be led by the Premier. Why is the Premier not taking the province's response to HIV and TB serious? Why is he delegating powers to the MEC? Nationally, the Deputy President, Didi Mabuza, is the one leading the Senec. Why the MEC of the Premier of Eastern Cape is not leading the Eastern Cape AIDS Council? Two, we are calling upon the Premier of Eastern Cape and the Eastern Cape government to inject more resources to civil society and the community-based organizations in order for civil society to be able to apply strategies and methods to reach out to communities and preach the gospel about prevention, preach the gospel about services that are related to HIV and TB. And lastly, we are calling upon the Premier of Eastern Cape to engage mayors and ensure that mayors are taking a lead in the functionality of the district aid councils, and the mayors must communicate the same message to the ward councillors to make sure that ward aid councils are functional. So we are trying to say here, all of us, we've got a responsibility, but we cannot continue to pay lip services whilst we know that people are dying. Thank you.
Thank you for your comments. I think there will be a lot of people who will be sending through questions, and hopefully we'll get some good responses from our panel. Okay, we are going to move to our second speaker now, and our second speaker is Uteka Nogoduka from the South African AIDS Council, and I believe that Ms. Nogoduka is in the venue at the ICC.
Hi, Cherry. Where's my presentation? I need the presentation.
Hi there. We're ready for you.
I'm supposed to share slides, so I'm trying to figure out where my slides are.
Okay.
Sorry, Cherry, about that. Oh, do you have to take somebody else? How do I get back to my Cherry, we
Yes.
trying to get my slides sorted. Probably I'll ask you to take the next speaker.
Shall we go to the next speaker? Okay, no
Yes.
problem. We'll move on while you get yourself sorted. Thank you. Okay, so our next speaker then is Dr. Ramnick, who is joining us on the webinar this evening. Dr. Ramnick, good afternoon.
Good afternoon, ma'am. Just let me know if I'm audible.
Yes, you're loud and clear on my side. Thank you.
Ma'am, I will also do a quick presentation, just about few slides to explain the approach that I will be explaining about the condition of COVID-19 and HIV during the COVID-19 pandemic. Will that be okay with you if I can proceed?
I'm sure that will be fine. You can go ahead, Doctor.
Thank you. And now I'm struggling. I had it on. I am so sorry, ma'am, also from my side too. If you can just give me a second, please.
Not a problem.
Yes, ma'am, I'm opening it. 1 second, ma'am.
Not a problem.
I wish I was intelligent enough to do this properly. Ma'am, can you see this presentation now?
Yes, we can.
Thank you very much. I'll be brief. I know I've taken some time out, so I'll be as brief as possible. Ma'am, I first of all would say all protocols reserved. I just don't want to acknowledge everyone's presence, but greetings to everyone. I'll be discussing about practically one of the modeling that we used is higher health towards the HIV response in parallel to COVID response. 2 decades of hard work from higher health and from post-school education, from our universities, our TVETs, and suddenly this pandemic of COVID comes, and it clearly pointed out that if we don't be proactive and if we do not run these pandemics parallel or prioritize one over the other, we will lose many gains of many other pandemics around the globe. And my appeal will be from my presentation is that there's high chance that we will falter further down into our gains of HIV pandemic should we not currently look into balancing the COVID pandemic that has happened, which obviously warrants our full attention at this moment. But how do we piggy bank on the infrastructure, the systems we are putting on COVID response, while we use that system to also make sure that the gains of the HIV pandemic, the 90-90-90 strategy of the HIV pandemic is prioritized across all districts, all 9 provinces, all sub-districts, all metros parallelly. And I think my presentation will be predominantly focusing towards modeling around how do we continue pushing efforts on COVID-19, pushing efforts on HIV, banking on the infrastructure, and the need of the hour is to put systems for the COVID-19, which is inevitably possible. Just to let you know, higher health works into these pandemics across this country and in the post-school education. And if you see this slide, from me, all these challenges, pandemics, vulnerable population are all interconnected to HIV. I can't think of a single area that cannot be interrelated to this pandemic of HIV. And this slide, if you're talking about gender-based violence has its highest correlation with pandemic of HIV, sexual reproductive health and human rights, mental health, and the kind of pandemic we see in post-school education in mental health warrants a massive response and its intersectionality to HIV pandemic in general. Similarly, drugs and alcohol. If 65% of gender-based violence in South Africa is preceded by substance and alcohol abuse, as per WHO, I will not be surprised if a similar amount of correlation comes up when we do scientific work with HIV pandemic. And these are all intersectional pandemics, and we need to, rather than taking an isolated approach, my appeal will be is to combine all this together and formulate a structural and work on building systems, controls, mechanisms, infrastructure as a country in strengthening towards fighting everything together as one voice, rather than saying we are an HIV or we'll tackle sexual reproductive health or GBV, because these are very cross intersectional pandemics. As much as I do believe that all of these needs technical experience, all of these needs further workup in individual compartmentalization of these pandemics, but these have a very big interrelated factors among them. There's a misnomer of higher education. Everybody thinks higher education is WITS or a UCT. But I want to remind everybody that higher education is just not universities. It is also a campus in Butterworth. We've got a campus of university in Zwalicha. We've got a campus in Mthatha in Queenstown. Parallelly, we've got TVET colleges. We've got about 86 campuses of TVETs around Eastern Cape. And when Eastern Cape AIDS Council or the Department of Health works on strategy, they must look at young lives in Eastern Cape, which are in Bizana, which is in a TVET campus, which are in deep rural in Mount Frere, Mount Olive, and these areas where we have a huge population of our young lives coming into our TVET colleges. our constitution has now warranted us to move into something called community education training colleges. Community education training colleges are a second inning house. If you are a dropout, you're a housewife, and you need to be employable. Most of our families, our generation, we've inherited a very difficult past. So our generations have been predominantly generations which have seen single parents, extreme poverty, violence. And the reality is that most of these are single mothers trying to build families. CET colleges allows young people to join into community colleges. And we've got 1,800 campuses countrywide, approximately 350 all around Eastern Cape, building a second chance to a human life, even if you're not a matric, and you can get some certificates to be employable. Not to forget, 20% of our population comes from private higher education. So this is a huge population of young people, of adults, coming for a next generation of economy in this country. The focus on post-school is very critical, as much as it's schools, is because if this population doesn't earn, this is the highest population which has the highest force of employability in this country. And the aim is, this is the hope of a mother who goes into a workspace and look after the family generations. And that's how every African family is built in. We cannot afford to lose a young life at early stages in our country, in especially a young life that is supposed to go and get educated after all the difficulties, enter a post-school education, and eventually have casualties because of HIV or gender-based violence and mental health. And I think that's very critical. One of this slide I wanted to pick up is, despite COVID, during lockdown 5, 4, 3, 2, and 1, we kept our HIV program continuing. As much as our colleges were closed down, universities were closed down. One inevitable reality we knew was that our education system cannot close down because we could not do our education system virtually, except for few of our privileged universities. People do not have data, people have no access to how qualifications can happen. So we had to open the TVET colleges. So we built a massive project on COVID-19. When we built a massive project on COVID-19, we had to build screening stations at every entrance of the gate so that students can be screened. If thousands of them were coming into the gates, they could be screened and then allowed in so that we can mitigate the risk factors in which screening was critical. We moved into fourth industrial revolution, which I'll speak about. We used digital technology, developed health check, where a green passport could be given every day and COVID-19 screening could happen. But then what we did was we emphasized for every volunteer of student volunteer or a staff volunteer doing COVID screening or built on the COVID screening station at the gate, to not forget HIV pandemic. Do not forget gender-based violence, contraception, sexual reproductive health program, condom distribution. And you will see from this slide, still we managed to do 63,000 students for HIV testing. For us, this was big, important factor. As much as there were enormous challenges of lockdown and prevention, we continued piggy banking on COVID infrastructure, which we had to establish for screening stations, entrance at the gates, classroom activities, COVID capacity building, COVID training. We had to build protocols. We had to build COVID trainings on security, on cleaning staff, on residents, on wardens, on student volunteers, on programs. And we emphasized parallelly that the same volunteers emphasize the HIV promotion program so that the gains are not lost. And I'm aware that my time is coming to an end.
Sorry, Doc, if I can just ask you, you have your presentation open, but it's still on the first slide. If you mind just moving to the slide that you
sorry,
are now.
I have been moving the slides, but maybe the slides are not moving at your end. I apologize. But from my side, I'm already on the 7th slide from my end. I literally apologize, but let me just finish the presentation then. I really apologize, but I'll make sure these slides are available to everyone. I just want to let you know that I thought everybody's seeing it, so I was not explaining too detailed, but we did about 64,000 students for HIV tests during level lockdown 5, 4, 3, 2, and 1, piggy banking on the COVID infrastructure. We did TB screenings, we did STI screenings, we did about 28,000 long-term contraception for young girls so that we can combat teenage pregnancies and engage on pregnancies, about 4.6 million condom distribution, peer-to-peer classroom session modalities on HIV, TB, STI. So the classroom activities, the peer-to-peer work, the HIV testing work continued, but continued under the umbrella of the COVID-19. But the aim is to keep on saying that we cannot lose the gains of the HIV due to COVID-19, or COVID-19 should not be a reason. In fact, COVID-19 should be an enabler to make sure that all the infrastructure that COVID-19 warrants us to put in every sector, whether it's higher education, basic education, because you have to put infrastructure of COVID screening, volunteer program, capacity building, system strengthening, structures, protocols. You need to integrate them with HIV. You need to integrate them with SRHR. 56,000 young girls on gender-based violence had to be supported during this period, including alone in post-school education system, empowered and supported, because these pandemics became absolutely silently growing under the COVID pandemic. The biggest worry for us was the mental health, the number of suicide cases, depression, anxiety. Today, people do not know what is there in for them tomorrow. The academic issues have started coming up. And all these stresses directly relate to HIV. All these stresses directly related to SRHR, as much as they are pronounced for COVID. So COVID has intersectionality with many of these pandemics, and keep on reminding that you can't remove them away from it. We started a 24-hour helpline. We put psychologists, social workers, 24 hours into a system so that we can manage students, to support students on mental health and sexual gender-based violence issues. We received 2,900 phone calls in just last 1.5 months of its launch. Clearly stipulates that how much the problem in our communities is, how much real stresses are sitting there when you open some kind of support mechanism and the population is hungry for support in that regard. These are 2,900 lives which were averted through severe crisis management. We're not proud of these crisis lines, but we are trying to appeal that there are massive challenges that COVID-19 has brought with us. We might be in a situation, UNAIDS recent studies, and I'm not going to take away from the other speakers that are going to speak about the UNAIDS results. They are very heartening to see a world and global, and South Africa and Southern Africa is making strides into the HIV pandemic. But with the reality is, we still continue to see young girls, we still continue to see young men, and even middle-aged men becoming positive at a very, very fast pace, including young girls before even at the age from 10 to 13. And the reality for this is our negligence and our ignorance towards prioritizing the HIV pandemic while the whole country is emphasizing on the COVID response. Now, I'll stop here. Well, I have a lot of other interventions to speak about, which is our digital tool, because all we are doing is all the infrastructure we have built on, which COVID-19 forced us to use technology, which went on USSDs or WhatsApps or web forms or apps. We're now going to use, in fact, one of the applications that we launched had 1.6 million students joining in 2 months for COVID screening. The question is, can we build on that infrastructure for providing HIV knowledge and services quickly through technology? And if COVID has brought technology as a forefront, then I think how we can piggyback on technology to make strides on the HIV pandemic. And that's going to be something that Higher Health and every organization in the world should be focusing and moving towards, in making easy access of services to our people in closest proximity during the COVID pandemic. So appeal is, COVID remains, and it's going to still continue for a little while, or even for a while that we do not know. But HIV gains cannot be forgotten and needs to be continued in parallel. Thank you.
Thank you, Dr. Ramnick, for your insights there, particularly around reproductive health and, some of the issues that we may not even have considered, as we look at the issue of HIV and COVID-19. Are we ready for Ms. Nogoduka to give her presentation?
Hi, Cherry.
Hi there.
Good afternoon, Cherry, Comrade Steve, colleagues in the meeting. This afternoon, I'm requested to give a quick presentation on the impact of COVID-19. The impact of COVID-19 on the NSP. So I've got a few slides that I wanted to talk to show you the graphs. That are showing impact of COVID-19 on the targets and the goals that we had set up for ourselves as we were planning the HIV, TB, and STIs response in the country. I think the colleagues that spoke in the previous conversations spoke about the impact of the three diseases that are colliding and the response that we would want to have to say, we want a response that is going to be comprehensive so that we ensure that we are able to respond to our health system, but also our community systems that are in crisis as we are actually responding to the three epidemics that are colliding in the country. In terms of the impact of COVID-19 on service delivery, I think Comrade Anele spoke to some of the issues around the redeployment of staff in the facilities to reprioritize COVID-19 activities. And these were health professionals that were in the facilities. We saw the decline in number of clients accessing facilities due to some of the regulations that were put in place that were minimizing our movement as individuals in the country. Clinics were closed temporarily as the staff were getting infected. I think one of the concerns that we had as the HIV and TB response was the reprioritization of financial resources that needed to respond to COVID-19, as we did not have budget set aside to respond to this epidemic. Some of the services were also put on hold for the risk adjustment strategies that were responding to COVID-19. In the next couple of slides, I'm just going to talk to numbers in terms of the different programs, but we want to focus on the Eastern Cape. If we're looking at the male condom distribution, you saw in the Eastern Cape, we had a negative growth of about 49% that we, during this period, which is April to June 2020, comparing it with this same period in the previous year. That's where you measured the growth. So if you look at what happened in terms of the condoms that were distributed April to June 2019, comparing to April to June 2020, we had close to a 50% reduction in those. Looking at the male medical circumcisions performed, Eastern Cape is still on the first row. Comparing the 2 years, we were at minus 95% coverage. So very minimal medical male circumcisions took place in the province during the time. Looking at the number of HIV tests done, comparing the two time periods, less than minus 30% of tests were done in the Eastern Cape. Looking at the positivity, number of HIV positive clients that were eligible to be started on the TB preventative therapy in the Eastern Cape were minus 40% if we compare the two time periods. Total clients started on ART, if we compare the same period, 2019 and 2020, we're at minus 26%. If you look at the PrEP uptake, this slide is talking to the entire country. If you compare the time period looking between January 2020, you look at this green graph in terms of public facilities that were providing PrEP, and you look between March, April, and May, in June 2020, that's where we see a deep dive in terms of the availability of PrEP. So this also is an impact of COVID-19 during those months when we started the lockdown. But if you can also look at the different colors that are on the graph, those are the different populations that would normally access PrEP in our facilities. If you look at our graph talking to the national TROA, that's total remaining on ART. So those are number of patients that have been on treatment over time that are constantly collecting medication monthly into our health facilities. And if you look at what has happened in June 2020, you can see that we started to see a decline in terms of the number of people that are accessing in our facilities. And if you look at the numbers, we need patients per month for us to be able to meet our targets by March 2021. In this slide, I just wanted to show the impact of COVID-19 in terms of the 90-90-90 targets. If you want to look at where the different districts are in the province, you would see the last 8 districts in the province, in the slide, are from the Eastern Cape, and you can see where we are. Overall, the first 90, we are doing well. We've met our 90% in terms of the testing. In terms of initiating patients on treatment, you can see that the highest district in the province that is at 73% is Chris Hani and Jokabi, but all other provinces are below 70%. We're looking at Nelson Mandela at 54%. If we're looking at the third 90, you can see also our third 90 in the Eastern Cape is red. We are not meeting the viral suppression. You can see that we are much below, with Chris Hani and Jokabi again doing a bit better than the rest of the provinces. They are at 60%. The rest of the provinces are at below 60% in terms of the viral suppression. And comparing that with the national target, at national, we are close to 85% in terms of the third 90. So this is a cause for concern for us in the province, because this means there are people that are not initiated on treatment that require to be on treatment. But there are those that are already on treatment that are not virally suppressed. So the amount of virus that is walking around in our communities in the province is a cause for concern. This is just looking at testing trends again and looking at our positivity. This is a concern that we have as program response for HIV, especially that during the lockdown, you would remember, Sherry, that there was a time when we started lockdown level 5, even condoms were rendered as a non-essential item to be available. So if you were not able to move and go to a health facility to get a condom, but also when you get to Clicks has put a red tape under the condom aisle, it meant there was no access for condom. So already we are starting to see spikes in terms of the HIV positive trends after lockdown, which is a result of the response that we had. If we look at TB, you can see that our gene expect testing was decreased during the time of from 1st April. You have not really recovered by 1st of October in terms of the number of TB tests done. This is twofold. One is based on the fact that the impact of lockdown regulations in terms of movement for people to access facilities, but also the fact that we were using the gene expect to test for COVID-19 had an impact on the test number of tests done. So for me, this is my last slide, just to say this is within the context of COVID, Dr. Ramnik has spoken to some of the approaches that we could use, but the moral of the story, where we are sitting with our numbers in terms of the response and what COVID had impacted on the services, because if you look at total remaining in care, those were people that were already on care and we've lost them during the COVID time. So we really need to pick up our response to take it forward to make sure that we are able to reach epidemic control by 2030. Thanks, Sherry.
Thank you for that. It does seem that there is quite a challenge that lies ahead in terms of just making up some of those numbers that were lost during the hard lockdown particularly. And hopefully, you know, as this webinar progresses, we'll be able to explore some of those interventions in terms of how we make up that lost ground and just move forward. Okay, so for now, we will move on to our next speaker, who will be Dr. Gaga, I believe, from Beyond Zero. Do we have Dr. Gaga on the call?
Hi, Sherry. Just for today, I'll be Dr. Gaga, but my name is Dr. Bulumko Fuchane. Dr. Gaga can't be with us today.
Okay, you're not with, okay. So it's Dr. Fuchane.
That's correct.
Thank you.
Let me just find my presentation also. Just bear with me. It's somewhere.
It was there.
No,
She did.
you want to take another one?
No.
Do you need more time to find the presentation? Should we move on to the next speaker in the meantime?
Which folder? Is it on the memory stick? Okay. Sherry Ann, go on to the next speaker.
Okay, let's do that while you try and get the presentation first there. Okay, our next speaker will be Mr. Mugabe from UNAIDS. Mr. Mugabe, you are on the call with us today, right? There you are.
Yes, I am.
Good afternoon.
Afternoon. I'm trying to put my camera on.
There you go.
Thank you, moderator, and thanks to my fellow panelists and those that spoke, before me. I think a lot of ground has already been covered. I just wanted to highlight just a few things in the interest of time. One, which was that early on in the pandemic, UNAIDS and WHO brought together a number of scientists and modelers to look at the potential impact of Covet on HIV services, but particularly their potential impact on new infections and on mortality. And from that earlier work, it was very clear that unless something is done, I think we are going to have a number of setbacks. One of the worst case scenario that was mapped out by that piece of work was that the worst case scenario in terms of disruptions would be that we would be set back 10 years into the AIDS response. In other words, losing all those enormous gains that we have covered over the years. And that was clearly a wake-up call for not only for government, but also for advocates, civil society and communities to make sure that, in fact, this becomes what drives our advocacy and also define what we need to do going forward. And I think for us, that was a very important piece of message. But the work also looked at what are which services need to be prioritized if we're going to mitigate the disruptions. And clearly, the study showed that one of the major impact will become from any disruptions from, for instance, access to treatment, to ARVs, because of the lockdown measures and what may happen in terms of supply chain, and also just production of ART and their availability. The second area of work was what area where there was going to be major impact was going to be on the transmission of mother to child infections, simple because of the gains that we have already made over the years in this particular area. So any slight disruption was going to have major consequences. So the message, having said that, is that this was then at the beginning of the pandemic. The good news is that that scenario has altered quite significantly. Altered in the sense that I think a number of governments, communities, civil society, and people living with HIV and others have actually taken measures to try to mitigate and slow down the disruption in services. So we have gained ground, but not sufficient ground, because let's remember that even before COVID, we are already falling short of the targets that have been set globally and also in the different national programs, and in the case of South Africa, in the National Strategic Plan. So we had lost the grounds on that. And I think it's important that as we move forward, we make sure that we close the ground in those areas. The panelists before me, Anele actually in particular mapped out some of the areas where we need to make sure that, in fact, we recover lost ground. But I think what is very clear is that we will only, what we learned, for instance, from the Ebola crisis, I mean, which is what we are also learning now, is that pandemics have massive disruptive impact in services generally. And we have also seen that happening. In order for us to get back to track, it's important that we look at those areas where we can actually make grounds much quicker. And it's very clear that what we have learned in the South African AIDS response is that communities matters, and communities need to be at the center of the interventions that we do. So what happened immediately after the disruption from Ebola, countries in West and Central Africa, particularly in West Africa, started developing what they called Ketchup plans. In other words, very deliberate measures on how they're going to close the gaps from the services that have been disrupted and cover lost ground. And I think this is what we need to do in South Africa. Let's also remind ourselves that HIV, even without the disruptions that have happened, has always been an ongoing public health emergency in a country like South Africa. Yes, there has been enormous progress, but that enormous progress compared to what we need to achieve, I think, gives us, a cause to pause, that there's no time for complacency, and that we actually need to begin to move in this space much more rapidly. Kaka also shared some data on where we have lost the ground in terms of services. And it's very clear that in those areas, for instance, in the second 90, where we were also already struggling before COVID, we need even to do much more greater work. We need to innovate and make sure that people can access services in the most friendly way. And also is about how we integrate services, because we cannot win the HIV battle without actually linking to the issue of intersectionality that Dr. Ramnik has mentioned. It's important that we look at what we need to do in terms of catching up, not just about what we do for treatment, but also what we do around prevention. And that also means what we do around sexual and reproductive health and all those other services that also got disrupted during this period of time. So the good news is that I think at the end of this week, we'll be releasing the World AIDS report for this year. And I think that report is going to show that we've recovered some bit of lost ground, but that we remain far, far short of the targets that we need to meet. So the clarion call going forward is that we need to make sure that we capacitate communities Communities need to have resources so that they can put in place programs that will help us to reverse the effect of COVID. Because let's remember that the impact will only happen at community level. This is where we need to invest our effort and our energies. I think I will just want to stop here and wait for comments and questions later on. Thank you.
Okay, thank you for that. And I'd earlier said, Mr. Mugabe, understand that it is Dr. Mugabe, so apologies for that. Just a note to everyone who's logged into the webinar this afternoon, please do leave any comments, questions, matters of clarity in the comment section below, the chat section, and we will try and get the answers from our panelists this afternoon. Okay, so I believe that we are now ready. Dr. Kutanya, are you ready for us?
Yes, Sharia.
There we go. Thank you so much.
So much.
The floor is yours.
Thank you so much, Sherry. So just to, let me just first say all protocols observed to everyone who's listening to this webinar. And just to give some background, before we can say we want to regain the lost grounds, we need to understand what grounds do we have first. And secondly, how did we lose these grounds for us to regain them? So we understand that South Africa has only about 0.7% of the world's population, but it is the home of almost 20% of the global burden of HIV. We rank among the worst affected countries for TB, especially the TB HIV co-infection. And then came in COVID about 6 months ago. That impacted on the economy and also disrupted our healthcare systems. And we all know, and you've seen that many hospitals have reprogrammed their units to accommodate COVID-19. There was a lot of loss of income as a result of the lockdown itself. On the supply side, many hospitals and healthcare facilities, the human resource shifted to COVID. That has resulted in limited services for other health issues. And on the demand side, we've seen a public that has avoided health facilities, and also they have been affected by transport restrictions. If I were to come closer to home, in the Eastern Cape, we know that Nelson Mandela Bay is the epicenter of the Eastern Cape epidemic. We've seen many hospitals stopping or restricting all the elective surgeries, and many units are closed to accommodate for COVID. We set up field hospitals within the stadiums and other warehouses to accommodate the COVID-19 patients. So the biggest question is, what is the impact of COVID on HIV care that we need to regain the lost ground? So WHO had a survey where they were looking at they surveyed more than 13,000 LGBTI people in more than 130 countries, where they noticed significant disruptions in access to HIV treatment because of COVID. They also picked up increased socioeconomic vulnerability. More than a quarter of people living with HIV reported difficulty with access to ART refills. What they found in the US is what we found also in South Africa, or specifically in the Eastern Cape as beyond zero. There were disruptions in pre-exposure prophylaxis care in the US. This is exactly what we saw over the last 4 months, 5 months in South Africa, where across our populations that we are following, adolescent girls and young women, men having sex with men, transgender people, where the uptake of PrEP was less than 30%, which is of concern to us. And also, I thought that maybe coming closer to home before I go to what I thought Dr. Mugabe was going to talk about, there was a study that was done in the Western Cape looking at the COVID and HIV in the public sector. Without boring you with statistics, so they followed almost 13,000 patients with COVID in the Western Cape. for every 100 people in the public sector who died from COVID, 52% of those deaths could be attributed to diabetes, 19% to high blood pressure. What is much more important to us and for the discussion today is that 12% of those deaths were attributed to HIV and about 6% were attributed to TB. That is of concern for us. So if we were to combine HIV and TB, we will be talking about 18% of all those deaths. I thought that Dr. Mugabe was going to talk about the impact of the COVID response in in low and middle income countries, countries like South Africa, where lockdowns have impacted both on transport of goods across value chain. I think he did mention that. Also the barriers to supply chain and the forecasted economic shock, which indicate fluctuation in the availability. So if you were to look at this graph, so it shows the impact of the 6 months of varying levels of treatment interruptions. So the light blue line that I've indicated here, if there was 100% treatment interruption, so which means everyone who was on treatment wouldn't be able to access their ARVs, we would see almost 560 HIV-related deaths. What is of concern is that even if it was only 20% treatment interruption, we will still see more than 110,000 deaths from only 20% treatment interruption. That is of concern for us. That's where we're talking about the impact of COVID to HIV. So if we have to regain any lost grounds, we need to zoom in to these factors that we are talking about. So we've seen from the World AIDS Conference that happened in July, there are a lot of data that came in looking at TB and HIV responses that are threatened by COVID-19. And also, what does the COVID pandemic mean for HIV, TB, and malaria control? In our context, we will focus on HIV and TB. So we are seeing things that probably we're not paying much attention to. Issues like mental health. I think Anela did allude to substance use, poverty, loneliness, and much more, which is much more concern for us, is the medical mistrust that's going to happen. As we've seen that public now is shying away coming to public health facilities because they fear of contracting COVID. The issues of food insecurity, housing insecurity, etc., etc. So for us as public health experts, we believe that the effect of COVID pandemic on the continuum of care, it is emerging as a substantial and a long-standing one, and it has dire consequences. It is posing threats, as it was alluded to, on HIV prevention, on testing, on treatment, and also other access to medication for other forms of care. So what have we done as Beyond Zero? Beyond Zero as a civil society organization and also other NGOs that are implementing public health programs in the country. So Beyond Zero specifically, there are 3 intervention areas that we're focused on in trying to regain the lost grounds. The first intervention area is how do we mitigate COVID-19 impact on HIV and TB programs? The first thing that we did was to protect essential HIV and TB services by adapting and strengthening the community-based service delivery. These include mobile services, door-to-door services, health posts. We establish safe spaces in Nelson Mandela Bay, in OR Tambo, specifically in Nyandeni. And these programs are peer-based programs. And these models, they ensure uninterrupted provision of core interventions for our key populations that we are following. We also strengthened linkages and layering of HIV and TB treatment. As I've indicated earlier on, that we've seen the PrEP uptake to be less than 30%. The other indicator that we saw that we were struggling with, where we've lost some ground, is how do we link those who test positive to care and make sure that they start their antiretroviral drugs and also remain on them. So for us to be able to come close to what Toteka was talking about in terms of the 1990. We, without linkage and failing to keep our patients in care, we will never achieve the second 90 and the third 90. So that's why we are trying to strengthen those linkages and the layering of HIV and TB treatment services. The second point under intervention area 1 is engaging the civil society, because we believe that our response must be multi-sectoral. Without civil society and other community actors, we won't gain much ground. So we worked through national and sub-national Senec structures to engage and involve civil society and other community actors to quickly adapt to the changes imposed by COVID-19. We raised awareness, we educated the civil society and other communities on COVID-19 public health response, and making sure that these are sustained, these services or these essential services are sustained. The second intervention area that we focused on as Beyond Zero was to reinforce the national COVID response. So what we did was to strengthen the coordination and the management of the national COVID response at all levels. Again, we're working closely with other NGOs and other partners with Senec sub-national structures at provincial level, district level, and sub-district level by establishing COVID-19 command councils. So in every district where Beyond Zero is implementing programs, we made sure that we established these COVID-19 command councils. We strengthened the establishment and the functioning of the district emergency response teams in all the areas that we work, and also other partners, they've done the same. So the second point under the intervention area that we focused on was to protect our frontline essential service staff by procuring and distributing the PPEs to essential service staff, infection control products and services that include decontamination services. We were also supporting the COVID-19 clinical management by implementing the virtual or digital systems for home-based care for all those eligible cases. And then the third intervention area that we focused on, as I'm about to conclude as Beyond Zero, was on the urgent improvements in health and community systems. So we strengthened the human resource for health by hiring additional staff to support the capacity needs identified. These included additional healthcare workers for screening and epidemiologists. We also trained many healthcare workers on COVID-19, and more importantly, of which I believe is a cornerstone of us regaining the lost grounds, we strengthened the community-based COVID-19 screening, testing, and contact tracing. So we established and strengthened these mobile COVID-19 screening and testing sites. We also support the implementation of virtual contact tracing innovations. So COVID-19 made us to take a step back and think, how do we move from the traditional vertical programs that HIV has pushed us into, so that we implement our programs horizontally, so that between different epidemics that we might be faced with, we don't have to jump from different model to another model. So if we were to strengthen our public health response, specifically by strengthening the community-based public health, that's where we will win. We don't have to adjust based on what kind of epidemic that we are faced with, because that's a cornerstone of any public health response. So in conclusion, we understand that COVID-19 is going to be around with us for some time. People living with HIV have higher rates of comorbidities. And we've seen in one study in South Africa where the mortality was much higher in people living with HIV. So there are concerns regarding mental health effects, substance use, and food insecurities. We believe as Beyond Zero that we cannot let the COVID pandemic cause us to lose sight of how far we've come in our quest to end the HIV epidemic. So despite this overwhelming need to respond to COVID, we must continue to move forcefully to end the HIV epidemic that is here and around the world. Thank you so much.
Thank you so much, Dr. Fuchane, for your presentation and for your insights. Okay, our next speaker is waiting to come up. It is Steve Lesike, the chairperson of Senec Civil Society.
Thank you so much, Cherry, and really good afternoon to colleagues, to my fellow panelists. I think a lot has been said, really, from Comrade Anele to Comrade Ramnik, Comrade Mugabe. All comrades have spoken and they have sung the same tone. And the topic today, which is really quite a very important topic on how we regain the lost grounds on HIV due to COVID-19. And you know, it is quite important topic because we can't go back. It means we must move forward. We must reflect on what has happened, and reflecting on what has happened is really about learning lessons, but not ignoring some of the issues that we have been warned about before, and we knew they were going to happen. And I think Eastern Cape, you know, it's a very important province, given what Koteka was talking about, and really also what we have learned from the Tembisa 4.3 study. Eastern Cape also contributes, you know, it's number 3 of, you know, a province that contributes to HIV incidence and new infections. And I think it's quite important to look at what the latest data is telling us, what the big concerns that are raised by civil society, particularly people living with HIV in this case, and the warnings that we have received about what is happening within the health response. We do recognize some of the gains, some of the work that is done by government, by the Eastern Cape government, collaborating with civil society to respond to some of the pressing issues at this level. But I think one thing that we should not be ignorant on, South Africa is the epicenter of HIV epidemic. And South Africa also is the epicenter, again, of TB, which Anele has pressed on that issue. But again, it's again the COVID response. We've got quite a number of pandemics that we are dealing with, and we can't ignore, we can't treat one as important over the other. It means that we have to take lessons. HIV, TB response has taught us lessons, and these were hard lessons because many people died, and we cannot afford to see many more people dying. Just yesterday, you know, there was an announcement of the number of deaths that were reported. South Africa is over 20,000 deaths. Comrade Anele was talking about the TB death. And if at all we actually are to list the TB death on a daily basis, we will really be in a complete, what he calls as declaring a state of emergency, which is quite key. We also, on the other hand, have to realize that we have gained, you know, experience as South Africa because our response to HIV is matured. And this allows us to strengthen the response to COVID-19 pandemic, which is completely largely to the points that Comrade Anele has raised of infrastructure, of access, and we have a wealth of scientific and medical expertise and community mobilization to control the dual pandemics of HIV, TB, but as well as COVID-19 as a response. I think it's quite important not to also ignore that COVID-19 on its own became a threat. We need to ignore these experiences that were shared by Beyond Zero, by Dr. Ramnik in this case. COVID-19 became a threat to the continuum of care in HIV and TB, and particularly on the substantial and long-standing, which is one where we're experiencing a dire consequence. And all the issues that all panelists were raising, it's now dealing with the dire consequence. So if we are to then speak about not losing the ground, is to actually immediately arrest this dire consequence. The fact that COVID-19 posed a threat. It did not only pose a threat on the issues of treatment, access to treatment, and as well as what is happening with the issues in relation to health workers and so forth. It also posed a threat on HIV in prevention program. You know, right now, when you listen to what Ms. Toteka was talking about, looking at our own country progress and the Eastern Cape progress on testing as well as treating HIV response. But when you also then look at what is happening on the HIV prevention as well, you know, we ought to be concerned that COVID-19's rapid transmissibility and the impending threat overwhelms, you know, already the fragile health response, the fragile health facilities, and it is actually endangering the gains that were made with HIV response. You know, how does this one pandemic affect the other? We've seen South Africa on its own accounts for about 20% of the global HIV infection. And we've also seen that the strides of prevention, access to care and treatment on HIV and TB that South Africa has managed. We've seen it, a success program that one cannot run away from and which we need to always look at it as best lessons. It's the world's largest ARV program. We've seen this as part of our lessons. But now, 9 months after the first case was reported in South Africa as part of the outbreak, which is then COVID in this, South Africa responded with lockdown to slow the rate of infection, prepare the healthcare system, but the redirection of resources has had enormous consequences for the provision of healthcare services for other diseases. And I think Eastern Cape have a big task. You know, you have a multi-sectoral response that requires us to arrest these consequences that will really deal with the issue of what is under threat, which is the HIV and TB program. So we need to look at whether we have redirected how much resources from HIV, from TB, from STI response, from GBV to COVID, and whether in the current instant or current mode, and even today, we are having this conversation on the eve of 16 days of activism, because we can't speak of what is happening without looking at the social determinants, the intersections that Dr. Ramnik and a representative from Beyond Zero spoken about, because money has been taken away from already existing programs to go and respond to HIV and to COVID response. And the impact really we know will be felt by people at the ground level. The impact will not be felt elsewhere. It will be felt by those who are in need for prevention efforts or interventions. It will also be felt by those who need access to medication. We know exactly when the lockdown regulations were put in place, those who are in chronic medication were given medication or needed to access those chronic medication. But access did pertain issues of permit, issues of movement, what happened with defense forces across our communities and taking over really disrupted access to medication. And we've seen with the slide that was presented by Toteka around how many people who did not get their chronic medication. But also it was not only access, but it was around the care and support for people living with HIV and those who are living with TB as well. This at the end of the day will bring medical complications, and at the highest of it is the risk of drug resistance, which will not only just be around HIV, but it will also be around TB. And the biggest of it all that we've seen was a nightmare of logistics, how the supply and transportation of medication due to travel restriction, how flights were cancelled, moving on treatment, patient moving around. These national lockdown restrictions restricted movement of individuals and those who need access to care. I think some of the issues that we need to deal with are the more difficult issues that are pressing around people who needs to continue to get HIV testing. We continue to say our first 90 is to get as many as possible South Africans or those in South Africa to get tested. We were not managing this, immediately when we did the Covet, we did not manage this accordingly, which means we said everybody must test or people must test for COVID and so forth, but we failed to test for HIV. We also failed immediately to ensure the screening happens for TB and as well as STIs. All these pandemics are big pandemics for South Africa. Similarly, we've seen that there has been very little number to initiate those who are new patients on treatment. The barriers to contraceptives, Dr. Ramnik spoke to that, medical male circumcision, the treatment of other sexual transmitted diseases. All these big issues affect us as Senec, as communities, as civil society, and all other stakeholders who are involved. We've seen different models that were presented. We've seen calls by different communities, civil society organizations across the country, calling on government that do not disrupt the HIV/TB programs. In fact, ensure that there is an integration of COVID in this response. We've seen countries across the country. There were other provinces that had drug stock out and with major first-line drugs. And Gauteng became one of the provinces that were reported at 19.6% of reduction of HIV medication collection. And I think it's really important. Northwest was also one of it. Free State was one of it. And we can't ignore what people need also at the cost of emergency. When we say emergency, that means our disaster plan must kick in, but disaster plan must not kick in to create new platform, new process. Our disaster plan must kick in to actually then say, how do we deal with already emerging a crisis, but at the same time, how do we deal with the crisis that we have been dealing with in our country? And I think what is key to also consider as part of the social determinants, it is important not to note that HIV epidemic, as Comrade Anele has said, is the key driver of the TB epidemic, which is likely to be similarly affected during the unprecedented times. Transmission of communicable diseases, HIV, TB, and COVID are underpinned by social dynamics. The socio-economic impacts, we can't ignore the vulnerability that many South Africans who remained hungry, who lost their jobs, who became vulnerable and became even more exposed to vulnerability because of basic needs, such as water, sanitation, and that we saw. And we need to consider, how does this affect people living with HIV? How did it affect and impact people living with HIV? The three epidemics collided, and they actually are critical to the public health programs. And all these learnings and lessons that we've learned over time, we needed to just optimize. And that for this call that Eastern Cape has made to say, how do we regain, the ground? It means that we need to optimize. We need to remain uninterrupted. What civil society in the Eastern Cape has called for, to say, include us, let us be part of the response in different districts. You can't expect civil society to be involved and you don't support them. You can't then have a provincial response without political will. And I think it's quite important. We've seen the pockets of excellence, but pockets of excellence are not enough. If at all, they are not consistent. And I think Comrade Anele touched on it. I don't have to repeat that. But what is key is that COVID-19 pandemic has diverted resources, as I've said before, of important programs. And these initiatives are costing the country and will continue to cost the country. And we can't afford to sacrifice these pandemics that I've spoken about. We have a responsibility to deal with the second 90 of getting people on treatment. We have a responsibility, as I've said, that Eastern Cape is the third contributing province on HIV infection, to close the tab of new infections, of HIV, of TB, of STIs, but as well as COVID at the same time, including dealing with the social issues such as gender-based violence and hate crimes. And our responsibility solely sits with getting people on treatment, getting prevention interventions out there, and continue to gain the response adequately as a multi-sectoral approach, but also don't reverse the gains. I will stop here because I think it's key. A lot of points were made by others. Thank you.
Thank you. Thank you so much for that. So just to give you an update on how we will be proceeding for the next couple of minutes, we are going to take some questions from members of the public who have logged into the webinar, and we'll put that to our speakers, and then we'll have some final comments and then closing remarks, and that will be the end of the session. So if you just give me a second, I will get to the first question. Okay, so one of the first questions from one of the members of the public: what happened to the rollout of medical ATM delivery services? Would this not alleviate non-adherence? Shall we maybe have
Shiri, there's a request that the question be repeated.
Okay, sure, I can do that.
It wasn't caught up first time.
Okay, so the question is, what happened to the rollout of medical ATM delivery services? Would this not alleviate non-adherence? So it has to do with medical ATM delivery services. Can we have one of our speakers? Maybe Dr. Mugabe?
Can we have? Okay. There's also a request that read all the questions and then the panelists only read 3 questions at a time.
Okay, I'll read 3 questions. Okay, so the next question. The next question is for Dr. Ramnick, and it's more a request. This viewer would like some help on how to access information regarding education and what to do if you do not have a matric certificate. There's just a comment about most of the time in our communities, if you have failed grade 12, there's nothing for you. So Dr. Ramnick, it's just a response. I remember in your presentation, you were talking about TVET colleges and just some of the educational programs being run in the Eastern Cape. So that is for you. And then Dr. Mugabe, this one is for you. Any chance Dr. Mugabe can share with the meeting lessons and strategies the other countries used to give life to these catch-up plans to respond to the disruptions caused by COVID-19? Okay, can we let's start with Dr. Mugabe, the last question.
Thank you for the question. I think in terms of lessons for the catch-up plans, I think what is absolutely critical is that any plan that you put in place, at least this has been demonstrated all over, other places, is that they need to be funded. A plan that is not funded is as good as no plan. So I think as we think about how we are going to move with these plans, we have to be thinking about where are the resources going to come from. So that I think whatever limited resources we have, and I think when we're not only just talking about what will come from Treasury, but we're also talking about what will be coming from other partners like the Global Fund, like PEPFAR, the big donors. These resources should actually go into ensuring that we actually sufficiently resource some of these Ketchup plans, particularly on those areas where we know that we can make a difference. And some of those have already been mentioned. I think we need to be, when it comes to actually increasing, for instance, the gains around the second 90, we need to be asking ourselves, what are the areas that we need to fund in order to be able to do that? And this will go to what are some of the non-facility-based interventions that we can actually do to ensure that people have rapid access to treatment, but also when it comes to prevention, what are some of the issues that I think Dr. Ramnik talked about around what are some of the platforms that do not necessarily need physical interaction, but that can actually drive our prevention program going forward. So for me, two major ingredients in terms of Ketchup plans. One, resourcing of those plans. Secondly, to make sure that communities are empowered to, in fact, participate in the implementation of those plans. Because at the end of the day, as Steve said, the impact will be felt at community levels. And we have actually demonstrated with the achievement that actually South Africa has made in this big treatment program in the world that we have, that in fact it has communities that have been at the center of driving some of these government strategies to make sure that people have access. So to me, those are the two major lessons that we have learned: resourcing and making sure that community are central to what we are doing. Thank you.
Thank you for that, Dr. Mugabe. Okay, Mrs. Noguduka, we have you there.
Cherry, I'll take the question on the ATM dispensing machines for ARVs. Just to remind ourselves that you remember that was a pilot project, and most of those ATM dispensing machines were either placed in the workplace or placed in the institutions of higher learning. So with COVID-19 coming, you all know that we were then removed from those facilities or from those sectors where we will be able to access. But I think for us as a country, the moral of the story is how do we take these pilot projects to scale as we continue to have little pilot projects taking place in different areas. During COVID, Western Cape used Uber to deliver medication to patients. So there's little innovations that have come up before COVID, during COVID, and post-COVID. So I think for us, as Dr. Mugabe had indicated in the Ketchup plans, we need to rethink how we deliver HIV and TB services post-COVID-19. We need to move away from the mentality of the brick and mortar approach of a health facility. So as we talk about the UNAIDS approach around community-led, community-driven HIV and TB responses, how do we take our services towards communities? So looking at Ketchup plans, we might look at expanding those pilot projects, including the ATM dispensing machines, the CCMDD program on its entirety, and looking at other innovations that are technologically based. Thanks, Chair.
Thank you so much for that response. And then Dr. Ramnik, so the question from our viewer, just wanting to know on how to act. Hi there, hi, Anele.
Before you give to Dr. Ramnik, can I add on what Mrs. Kotaka was saying?
By all means, do so.
So this, as Mrs. Kotaka is saying, this is a good innovation. Because if you notice, on many occasions, our clinics are overcrowded not by people who are sick and who are in need of seeing a doctor or a nurse, but most of the people are going to clinics to collect their medicine. So these innovations are kind of reducing the overcrowding in our clinics, but not everybody is dependent to CCMDD or ATM, only those who are stable. And that is going to help many people who are adhering on their treatment to be able to access their treatment and also not to be delayed on their daily activities. Because on a number of occasions, we have seen people waking up as early as 5 a.m., queuing in clinics to collect their medicines, and people are only served after 1 o'clock. And as a result of that, they are unable to go to work and all what have you. And in such instances, they default on their treatment because of the overcrowding in our clinics. Thank you.
Thank you. Thank you for your insights there. Dr. Ramnick?
Jerry, thank you. In fact, I'm so grateful this question came up because this question is answering on many queries that I have always been raising around. Number one, and I'm going to answer the question, which is where to get access from for education, which people do not have metric certifications around. But to answer the first big point, why this question is so important is education is prevention. Education is the only way we can build skills in our country and skills development where people can become employable. If we can build employability among our people, we can kill poverty. If we can kill poverty, we can kill HIV, we can kill many of these epidemics that we are engaging. So I'm so happy that somebody from the audience has picked up this up to say, well, there is a hope towards education, even though there was no certification on finishing grade 12 or metric around. And yes, I am pleading you to please visit your nearest TVET college, your nearest CET college, whether you are in a rural community, you're in a peri-urban, suburban, semi-urban, and informal settlement, or urban. Should you not have metric, should you have not completed if you've just done grade 8, we offer certificates, diplomas, qualifications that help you with community education skills that will help you with skills development around employability. Things like community trainings, our plumbers, our miners, electricians, fishery industry, the massive automobile industry in the Eastern Cape, which creates employment. And I can tell you, and I would request that please reach out to skills development prospects, get educated. And there is nothing better than we transforming our generation through education into moving into the next phases where our children will be educated and come up with chances of more employability because of skills courses that they would have gone through. So Cherry, my aim is to reach out TVETs, to reach out CETs, even if you're not done your grade 12, you do not have certificates, and try to get educated and get skills courses so that one can be employable. Thank you.
Thank you for that, Dr. Ramnick. Okay, so let's just go to another question. So, I mean, this is open to any of our panelists. Why are we, as HIV positive individuals, local HIV activists that have a footprint in the public sector not put to use? We are trying to make an impact on our own. We are well informed and capable in getting to grips with encouraging people to test and adhere to meds. So, I mean, that's open to any of our panelists. Just asking the question around, you know, the involvement of HIV activists in helping to, regain that lost ground. And then another question that has come up quite extensively is the issue of funding. What is the current situation with funds being diverted? And are we now seeing a return of funds meant for HIV programs to HIV programs? And then just another question, what can we do to mobilize communities to take a more proactive approach to health and, the HIV epidemic? Okay, shall we, any of our panelists open to answering the first question around involving HIV activists and people living with HIV in their programs?
Shiri, we had lost some of what you had asked. We are experiencing network instability at the moment.
Okay. Okay, so maybe let's do this. So let's to make sure that we don't lose track. Maybe we can have Dr. Mugabe from UNAIDS, or maybe even Ms. Nogoduka, just answering the question about the involvement of HIV activists in these campaigns to try and, reach out to communities more. The comment that came out from the public is that we are trying to make an impact on our own. We are well informed, and we are capable of getting to grips with encouraging people to test. So that will then hopefully erase that slide that has been seen during the COVID pandemic of people not going for testing or defaulting on their treatments. Dr. Mugabe?
Thank you. I thought Anel was going to answer the question. But I think, people living with HIV are central to what we do. And I think we have also seen over the years that we have actually, because of, can you hear me?
I can hear you, Doctor.
Okay. No, I was going to say that I think in recent years, we have actually lost some of the capacities that we have built over the years around treatment literacy, around making sure that, in fact, people living with HIV are leading in this area. And this was largely because of issues around funding. So unless we can actually get funding to organizations of people living with HIV and other civil society and community-based organizations that are working in the community, I don't think we'll be able to make the headway at the pace that we wish to make it. So for me, I think what is central is that we need to restore some of those community-based services, including work that were done around adherence counseling, around getting people back into treatment, that organizations of people living with HIV have been doing in the past, and make sure that they get the resources that they need to do so. But as I say, I think it's also about whole communities and whole other groups that are actually activists in the communities, just to make sure that, as other colleagues have said, it's also about the fact that we are mindful of the fact that every service has been disrupted by COVID. And for us to be able to address some of this issue, we need all community-based organizations and civil societies to be equally capacitated so that we can deal, for instance, with the issues of gender-based violence, we can deal with issues of sexual and reproductive health. So it's really about how do we make sure that we don't just pay lip service to the centrality of communities, and especially for people living with HIV, because there's nothing in for them without them, and making sure that we stick to the principles of greater involvement of people living with HIV. And I think this is something that I think we need to make sure that I think we take forward much more aggressively and without just paying lip service to it. So I want to urge that I think communities in their diversities are so central. And it's also about, for instance, communities around key populations. We know for a fact that unless we deal with this elevated level of infection among female sex workers, we'll never get ahead of this pandemic, and we will continue to lose ground. So it's really making sure that we get those communities to be able to address the issues in their own communities, whether you're talking about the LGBT communities, whether you're talking about adolescent girls and young women who are a clearly vulnerable population, to make sure that they actually drive the programs. So it's about involving and letting people who are actually directly affected to drive the programs, because I'm not sure that there's anybody who knows better and have lived experiences than communities of people living with HIV, communities of different groups of key populations. I think for me, something that I think we need to make sure that we ratchet up as we go forward.
can I just add on Ukhombe Mbolawa Mugabe? I think two things on top of what Ukhombe Mbolawa Mugabe has just said. One, there are many community-based organizations formed and led by people living with HIV, which are doing lots of good work at local and community level. But the only thing that we are experiencing is the fact that they are not recognized by big donors. If they are given a funding, it's a little amount of money given to them, and most of the time donors are recognizing nationwide organizations or organizations that have a footprint across the country, which is a problem. And two, when you go on the ground, I think it is important that we send a clear message to politicians. Most of the time, the politicians do not like to work with people who are sharing different views with them. Politicians, they like to work with people that they have captured. So most of the time, organizations that speak truth to power are always kept at the distance by the politicians. And this is one of the elements that we need to fight within our society, to say, let's put politics aside and let's be able, all of us as a collective, to be able to address issues the way they are and do not judge people based on their views. Thank you.
Thank you for that. Anele, you were mentioning, it has to be the relationship between, civil society, government, that really is key to making sure that we prioritize these programs. But I just wanted to ask you, how can, civil society forum make sure that it advocates for government to continue to prioritize these programs? I mean, how do you get beyond these challenges that you are raising?
I will give you a typical example. One, like for instance, in Eastern Cape, we are told in Eastern Cape that the chairperson of the Eastern Cape AIDS Council is the MEC, which is wrong. It must be the premier, because the premier holds the political power in the province. And when issues are discussed by civil society in the presence of the premier will be able to provide the political instructions to the people that he works with, to the mayors and everybody. And two, it's only when the government and the business don't take civil society just as an additional voice, but they take civil society as one of the role players and as one of their equals. Because on many occasions, government and business, they have a tendency of undermining the voices of the community. And as a result of that, there are legal resources that are provided to the civil society in order for them to be able to work on the ground. That's why it is important that all of us, we must practice what we preach. For a typical example, if you were to write an email now and request a meeting with the MEC office or the premier, you can even have it after 2 years, because they don't recognize the civil society. They only recognize the civil society and community-based organizations only when they want to be voted into power. But when it comes to provision of the services, they don't recognize them. And when you disagree with them, you're going to become an enemy of the politicians. Thanks.
Thank you. Thank you for that. There is certainly, I think, room for further discussion there. Steve, I see you've got your hand up. Would you like to provide some input?
Yeah, well, I think, it's just to add on the most important comments. We can't do the response alone as individual stakeholders. It is quite important that the approach to dealing with, one, the issue of multisectorality. HIV response has taught us multisectoral approach. That's number one. Covet also has taught us multisectoral approach, even within these 9 months since the outbreak in South Africa. TB requires multisectoral response, which means the points in which we leverage on the already existing resources that have been allocated. It's billions of money, by the way, just to then say that our response and we need more resources. We know, when we were developing the NSP about 3 years ago, our strategic information approach did indicate, and even the investment case indicated, that we need to spend more in order to reap the benefits after this response. But spending more, it means that you must take the resources where they need to be going. They need to go to the local level. What Mugabe is saying, it means that those key stakeholders at the local level that are implementing interventions that have been proven to work must be the ones that lead the change. Because also reality is that these resources have continued to divide society, and they divided society because we did not invest in the community groups like Mamtambo in Lesike, who has been working for a very long time, 20 years ago, before the emergence of these big organizations, right? It means that when the big organization, if this money gets closed, these big organizations close the doors and they go. So that means investment must go to the local community-led interventions. I think it's very key. But one thing that we also have done and we are doing at the moment is to actually find a very systematic approach between how government and civil society, private sector, and development partners are going to work. So that framework in which will actually force not only Department of Health, because HIV, TB, and STI response is not only a health agenda, it is all departments' agenda. And we are seeing the Department of Health that has been instrumental, sure, but we want to see many others, such as higher education, basic education, as Dr. Ramnik has said, social development, and many others. So that means that the framework that we are building will actually marry the response in a multi-sectoral approach so that we don't operate in silos, but as well as we don't invest our efforts where they are not needed. We must invest our efforts where they are needed the most. Thank you.
Thank you for that. Okay, so we have a question here for Toteka. It has been reported that South Africa will not meet its 19-19-90 targets because of the impact of COVID-19 pandemic. What are the most important elements of the catch-up plan? Now, I know a lot of our speakers have touched on exactly what we need to do in the coming months, years for South Africa just to get back on that trajectory. But what are some of the key elements that should be the focus going forward?
No, thanks Sherry, for that question. Just a comment to say, as Dr. Mugabe had indicated, we can't blame it all on Covet for 2020. Therefore, we are needing to make sure that as we go forward, we look at the systems that we put in place for our program before COVID came and interrupted us. In terms of the catch-up plans, I think what is critical for us is to ensure that we meet the second 90. We know people that require treatment, and we just need to go and find them. We've got about 7.7 million people living with HIV. To date, we've got about 4.8 million of those people currently on treatment. So we've got about another 4 million people that we need to go and find and put on treatment. And the challenge that we have, as Steve had indicated, if we are not closing the tap, currently we've got about 220,000 new infections every year. So while we're trying to catch up on the difference of between 7.7 and 4.8, we continue to add new infections in that pile. So our catch-up plan needs to be multi-pronged, focusing on prevention, but also ensuring that those require treatment are initiated on treatment. And I think during COVID, we've seen that a health facility approach is not going to take us far. So we need to really pull together to ensure that we strengthen our community-based interventions at community level. The private sector needs to come to the party. If you're looking at the age groups that are HIV positive, that are also being infected, that is a working class, and we need the private sector to make sure that people that are at work or in the workplace are having access to treatment. Dr. Ramnik will give you numbers in terms of a number of learners or students within the tertiary institutions. And that is the future of our workforce in the country. So we also need to go to institutions and find people where they are to be able to provide both prevention as well as treatment to make sure that we can get to the third 90. So in a nutshell, our Ketchup plan has to be multi-pronged, focus in all the leaking elements of the cascade and making sure that the key and vulnerable populations are able to access the services that they need. Thanks.
Thank you so much. Okay, so we have time, I think, for one more question. And there might be just a slight repeat of maybe what some of the speakers have already mentioned here. And then after that, we will have a short presentation, not presentation, but some inputs from the health department, and then we'll do closing remarks. So let me just read the last question. There has been much talk of funds drying up. How can you as development partners make sure there is sustainability of these programs? You know, that's, I mean, funding has come up as one of the key issues throughout the webinar this evening. I mean, so what can you do to ensure that these programs are sustained going forward?
If I may, I'm sure other panelists would want to answer the question, but I think for me, central to the question of sustainability is how do we prevent new infections in the first place? Mm-hmm. If you cannot deal with prevention, you cannot talk sustainability. No amount of money would help us to treat ourselves out of this pandemic. So critically to what we are talking about with the catch-up plan, it's not just catching up around the lost grounds on treatment, it's also the lost ground on our work in prevention. Our work in prevention has suffered. Probably if there's an area where we need speed, it is, and agility is around our prevention program. There's no issue, question of sustainability without addressing the question of prevention. It's at the heart of what we are doing. And as Koteka said, we can't keep on adding to the pool of infected people and expect that we will get money to continue to treat people. So prevention for me is the fundamental of any question around sustainability. I think we need to start there and get the foundation right, deal with cutting-new infections, making sure that we can actually go back to those programs that, as Steve said, are really multi-sectoral in nature. It's about inequalities, it's about vulnerabilities. It's not just about accessing biomedical interventions that exist today to reduce new infection. It's about reducing vulnerability. It's about ensuring that we stop new infections, particularly in those populations, female sex workers, who in fact are the only group that have elevated infections that is more than adolescent girls and young women, which is the group that I think we're extremely worried about. But when it comes to female sex workers, we have a massive ground to cover. So for me, I think if we should not only be talking about sustainability in terms of finance, it's also about program sustainability, making sure that the program for stopping new infections are sustainable. We cut new infections. So for me, that's the fundamental.
Thank you for that, Dr. Mugabe. Do we have any other remarks from the panel before we wrap up?
Can I come in? It's Anet.
Yes, please, Anele. Are you able to put your video on?
I am unable. I've been struggling.
No, that's fine.
So
if you can just give us your remarks quickly.
The two things that we didn't speak about here are the issues of the corruption within the Department of Health. And the second one is what we see happening in provinces like Free State, where you see some of the staff members working for the DOH conniving with criminals to steal ARVs. I think as communities, we need to stand up and fight against the people who are stealing ARVs within our healthcare facilities in order to sell them to the streets of our communities. Thank you.
Thank you. Thank you so much, Anele. Yeah, thank you for your question. I'm hoping that we'll be able to explore that maybe a little bit later. Maybe on another program. We are fast running out of time at the moment. So if we can we'll just have two more speakers, and if I can just ask those speakers that when they come up that they try and keep it as short as possible. We are running out of time. Up next is Miya Nokwe from the Department of Health, the Chief Director within the Department of Health, who will give us some short remarks, and then we will have closing remarks from Dr. Kolu. Do we have Miya?
Oh, okay. Thank you very much, Program Director. As the Department of Health, we have acknowledged all the presentations and the comments, but what I must say we have learned during the COVID-19, we still have COVID-19 anyway, is that we should always put our communities in front. We should integrate our programs. So the challenge is, how do we ensure that we continue rendering our services using the community-based public health interventions outside our facilities? That I think could ensure that our patients, they continue to get treatment without any disruption. So as a province, we have already developed the
I think we're having some technical difficulties there. Okay. Yes, so our final speakers have dropped off from the call, unfortunately. Would it be possible for me to ask one of our other panelists just to make some closing remarks so that we will
there they are, they're
wrap
back.
up. Oh, they're back. Hi there.
Hello.
Hi, sorry, I see you dropped off the call.
Yes. No, I think
okay.
we also acknowledge that as a province, as you would know, that we're still the epicenter of the COVID-19. You know the numbers, even we do have Nelson Mandela, Sarah Parkman, and even other districts, they are trying to, there's gradual increase in the numbers. But I think what we need to ensure is to say, although we do have COVID-19, when we go out to do contact tracing and tracking of patients, we also integrate our HIV and T. In fact, the whole sexual reproductive health program we should ensure that there's a package which is part of our COVID-19 interventions. So as a department, we will ensure that we always work with our communities and ensure that our patients that we have been shown that in terms of second 90 and the third 90, we still have huge gaps. And I think we, in spite of what we are currently facing with, we need to work very hard in ensuring that we try and improve our performance on our second and third 90. With those few words, thank you very much to everyone.
Thank you so much. And then finally, we will have Dr. Kolu.
Thank you, Shari. Just
okay,
to be Dr. Kulu again. Good night. Colleagues, we just wanted to thank everyone, particularly our panelists. We know, colleagues, that you are always reliable partners to us. I think ours for today, we just wanted to start and open a discourse. And I hope that this discourse is not going to end today. We just want to make sure that we take all of beautiful contributions that we've had forward. The HIV Compact is one of the most successful compacts in South Africa, in spite of its many challenges. Let's make sure that we keep on the partnership, and let's make sure that we reach our most admired vision, revered vision, 2030 vision that says AIDS-free generation. So colleagues, with those few words, we want to thank you very, very much. Thank you to our program director. Thank you so much. Thank you, colleagues. Bye.
Thank you so much for that. And that means we have come to the end of this webinar. Thank you to everyone who has logged in and who has participated. And thank you to all our panelists for sharing, the insights and, knowledge on the topic. And, it's a massive program and it's a challenge going ahead. But I'm sure as a province and as a country, we are able to overcome these challenges and, regain the lost ground. Thank you and good evening.